Our second pediatric neurology lecture will encompass neurological infectious diseases. We will start by talking about torch infections. The original concept involved toxoplasmosis, other infections, which primarily included syphilis, rubella, cytomegalovirus, and herpes simplex virus, thus the torch mnemonic. Now there are other well-known causes of in utero infections, including enteroviruses, varicella zoster virus, parvovirus B19, as well as Zika. The American College of Gynecology recommends that pregnant women in the United States be screened for rubella and syphilis at their first prenatal visit, and other screenings are only usually done depending on clinical suspicions. We'll start by talking about congenital toxoplasmosis. It is caused by a protozoan parasite called Toxoplasma gondii. The primary infection in pregnancy can result in congenital disease. The symptoms include fever, a maculopapular rash, hepatosplenomegaly, microcephaly, seizures, jaundice, thrombocytopenia, generalized lymphadenopathy. The classic triad is chorioretinitis, hydrocephalus, and intracranial calcifications. Congenital syphilis is caused by transmission of the spirochete treponema pallidum from the mom to the fetus. Infection can result in stillbirth, hydrops fetalis, or prematurity. The symptoms include fever, hepatomegaly, lymphadenopathy, failure to thrive, rash, jaundice, anemia, thrombocytopenia, leukopenia, pseudoparalysis, meningitis, seizures, visual problems, or deafness. In these photographs here, you can see some of the changes that can occur in the bone structure with congenital syphilis, as well as changes in the teeth that can also be seen with syphilis. Congenital rubella typically leads to problems with sensory neural deafness, cataracts, cardiac malformations, growth retardation, hepatosplenomegaly, thrombocytopenia, what are called blueberry muffin skin lesions, and hyperbilirubinemia. Congenital CMV leads to sensory neural hearing loss, cerebral palsy type symptoms, intellectual disability, vision impairment, seizures, petechiae, jaundice, hepatosplenomegaly, thrombocytopenia, microcephaly, intracranial calcifications, and chorioretinitis. This neuroimaging shows some typical calcifications that would be seen in CMV. Herpes simplex virus is transmitted to the infant via an infected maternal genital tract. The risk of transmission is greater with a primary herpes infection acquired during the pregnancy, especially if acquired near the time of labor. There are three patterns to these infections. It can be localized to the skin, eyes, and mouth, which is called SEM. It can be localized CNS disease or disseminated disease involving multiple organs. The initial manifestations of CNS disease can be nonspecific, such as temperature instability, respiratory distress, feeding problems, or lethargy, but it may rapidly progress to low blood pressure, jaundice, disseminated intravascular coagulation, apnea, or shock. This is a picture of some of the typical type lesions that may be seen on the skin with a neonatal herpes infection. Congenital varicella syndrome mostly occurs in infants whose mothers were infected between 8 and 20 weeks of gestation. The features include cutaneous scars, cataracts, chorioretinitis, microphthalmos, nystagmus, hypoplastic limbs, cortical atrophy, and seizures. Congenital Zika syndrome has a greatest risk with first trimester infection. The features include microcephaly, facial disproportions, hypertonia, hyperreflexia, seizures, irritability, arthrogryposis, eye abnormalities, sensory neural hearing loss, intracranial calcifications, and enlarged ventricles. This is a picture of a baby with congenital Zika. As you can see, the head is very small in proportion to the other body parts. We're going to move on now and talk about bacterial meningitis. Incidence changes depending on the year of life that we're talking about. In less than 2-month-olds, it's 80.69 per 100,000. From 2 to 23 months, it's 6.91 per 100,000. 2 to 10-year-olds, 0.56 per 100,000. And then 11 to 17-year-olds, 0.43 per 100,000. So clearly in the little babies, we have the highest incidence. Causative organisms also change depending on the age group that you're talking about. In the neonates, our bugs of choice are group B strep, E. coli, and listeria. In those greater than or equal to 1 month to less than 3 months of age, we see predominantly group B strep, gram-negative bacilli, strep pneumonia, and Neisseria meningitidis. In those greater than or equal to 3 months to less than 3 years of age, we predominantly see strep pneumo, Neisseria, group B strep, and gram-negative bacilli. In those greater than or equal to 3 years to less than 10 years of age, it's strep pneumo and Neisseria. And in the oldest population, it's primarily Neisseria. Presentation for bacterial meningitis includes fever, although it can be just temperature instability one way or another in a neonate, nausea, vomiting, irritability, anorexia, headache, confusion, back pain, nuchal rigidity, seizures, or apnea. We have 2 signs that can be checked in older kids. A Koenig sign is present if the patient, while in a supine position with the hip and knee flexed at 90 degrees, cannot extend the knee more than 135 degrees, and or there is flexion of the opposite knee with this maneuver. The Brzezinski sign is present if the patient, while in the supine position, flexes the lower extremities during attempted passive flexion of the neck. CSF findings with bacterial meningitis involve a white blood cell count that is typically greater than 1,000 with a predominance of neutrophils. The glucose is less than 40 in more than half of cases. The protein usually ranges from 100 to 500. On your gram stain, if you see gram-positive diplococci, you think about strep pneumo. If you see gram-negative diplococci, you think about Neisseria. Small pleomorphic gram-negative coccobacilli, you think about H. flu. If you see gram-positive cocci or coccobacilli, you think about group B strep. And gram-positive rods and coccobacilli, you think about listeria. Treatment for bacterial meningitis involves a typical regimen of high-dose third-generation cephalosporin, such as cefotaxime or ceftriaxone, with vancomycin. You can consider the addition of dexamethasone before or concurrently with the first dose of antibiotics. And if you are dealing with listeria, you would use ampicillin and gentamicin. Now we're going to switch over and talk about viral meningitis. Clinical features in neonates involve fever, poor feeding, vomiting, diarrhea, rash, respiratory symptoms, seizures, irritability, and lethargy. In older children, we would see fever, headaches, nausea, vomiting, stiff neck, and photophobia. The CSF findings include white blood cells ranging from about 10 to 500. Glucose is usually normal or slightly reduced. The protein is typically normal or mildly elevated, but is usually less than 150. Possible etiologies include enteroviruses, herpes viruses, arboviruses, lymphocytic choriomeningitis, flu, or rabies. For treatment of herpes, acyclovir is recommended for children with CSF pleocytosis who have encephalitis, focal findings on exam, or imaging, or EEG, you may start it with less information in a neonate, just to be on the safe side, until you have your results back from your HSV PCR. These are our references, and this concludes our discussion of infectious diseases with ties to neurology.